I have a patient with a swollen first MTP joint. It's probably gout, but it's never happened to him before, so I better tap that joint. And you know, that's a small joint, so I probably need to use ultrasound. I think I have a student on the ultrasound rotation. Hey, Eli! First, we will examine the MTP joint with ultrasound to see if there is an effusion. Optimal patient position for this is with the patient supine or seated with the knee flexed and the sole of the foot flat on the examining surface. Since we are examining a superficial structure, we will use the linear high-frequency transducer. If you have a high-frequency hockey stick transducer, you might want to use it for pediatric or smaller joints. We have selected the superficial preset on our ultrasound machine to optimize our view of the joint space. Eli is applying a thick gel cushion to the anterior aspect of the MTP joint. This joint is best examined in the sagittal plane with the transducer on the superior medial aspect of the foot. In keeping with standard ultrasound convention, the transducer indicator is towards the patient's knee. The transducer indicator corresponds with the indicator marker on the screen, so the patient's knee is to the left of the screen and the toes are to the right. The ultrasound images of this view demonstrate the first metatarsal on the left side of the screen and the great toe on the right side of the screen, and the normal joint space is in between. Notice how the joint space is opened by flexing the toe. When an effusion is present, an anechoic or hypoechoic area will be seen pushing out of the joint space. Now that we've established the presence of an effusion, we need to perform an arthrocentesis. That effusion looked pretty small to me, so I'm going to use ultrasound to make sure I get the fluid I need for analysis. Arthrocentesis is a sterile procedure, so we have prepped and draped the joint. Our syringe and needle are on the sterile field. In addition, the ultrasound transducer has been covered in a sterile transducer cover, and we are using sterile gel. Please see the Access EM procedural video on ultrasound-guided internal jugular vein cannulation for a demonstration of how to apply a sterile probe cover to the transducer. The ultrasound machine is placed just to the patient's right, so Eli can see it with minimal head movement. The skin over the arthrocentesis site has been anesthetized, and we are ready to proceed. The transducer is held by the left hand in the sagittal plane, and the toe is flexed and extended slightly to maximize the effusion size. The center of the long face of the transducer is placed directly over the middle of the joint space. A 19 or 20 gauge needle attached to a syringe will be inserted at the center of the long face of the transducer, angled just slightly towards the transducer. Placing the joint space in the center of the screen and then placing the needle at the center of the transducer is key to successful needle placement in the joint space. Insert the needle right next to the middle of the transducer. The hyperechoic needle tip is visualized in the center of the screen as it enters the joint space. Once the needle tip is visualized, gently draw back and voila, joint aspiration is complete. Identification of joint effusions and joint aspiration are easy with ultrasound. The keys to success are preparation, proper positioning of the joint, and accurate alignment of the needle with the transducer. The next time you have a patient with a swollen joint, take a look with ultrasound.